a very good and clinical practicing question. We do have this rule. We don't use the glycoprotein inhibitors in those patients who are troponin negative. We do use them in those who are troponin positive, and in those who are troponin negative, and we do it routinely now in all patients. We test them for their reactivity to aspirin and clopidogrel. And if they are poor responders, then we use tirofiban in those who are troponin negative.
But I was talking about patients with STEMI, who by definition are all troponin positive.
Yes, we do use them.
In all patients?
In all patients.
Yes.
Thank you for the good talk. I have two questions. Number one, use of GPI in the diabetic subset of patients, whether they are stable or unstable presentation. Number two is, do you frequently or you do the routinely check for platelet reactivity in every and each patient you catheterize?
Yes, we do that. I have to tell you that we are a small group. We don't do 1,000 of catheterization, but we do 1,600 per year. And we do check for each patient. The tests are available, rather cheap, and then rather cheap in comparison with the cost of the stents and the cost of a thrombotic event later on. Can be done in 2 hours, and so we do it now routinely, and we are quite happy. We do routinely after this clinical trial.
And the diabetic patients or the GPI?
Sorry?
The use of GPI in diabetic patients?
In diabetic patients?
Yeah, glycoprotein inhibitors.
To be quite honest, I do not know whether we do it routinely or not. It is just an indication related to the patients, related to the reactivity related to the platelet reactivity, and there is no routine use of it.
Thank you indeed for coming for the second time to Alex. I hope that would be better. And I would like to thank you again for this very well illustrated lecture. Now, my question is, we don't have, as Professor Tobli said, abciximab, which is disadvantaged in Egypt, but we do enjoy having tirofiban and epipeptide. In the setting of primary PCI, do you have any preference for any individual 2B3A in your experience to use? Does one of them have an advantage or have the edge over the others?
Well, I think you are lucky in Egypt. I know that I'm very unpopular, but tirofiban is cheaper than abiximab, and we have been criticized in my country because we use it a little bit off-label in acute coronary patients. And I think that tirofiban is better because it has less side effects than abiximab. So don't consider yourself necessarily unlucky. It's a very good drug, and it is cheaper.
Thank you.
Thank you very much.